Your pancreas is working overtime right now. Not occasionally, not just after meals, but continuously throughout the day, producing elevated levels of insulin to keep your blood sugar within the normal range. That compensation is happening in the beta cells of your pancreatic islets, cells that are secreting 2 to 3 times more insulin than they were 5 years ago to achieve the same blood glucose control, and the effort required to maintain that control is slowly exhausting your metabolic capacity. Fasting glucose is not a comprehensive measure of metabolic health. It is a single snapshot of one variable at one moment in time. After an overnight fast, when your body has had maximum opportunity to stabilize blood sugar through hepatic glucose regulation and whatever insulin secretion is still available. When that single measurement comes back at 92 or 95 milligrams per deciliter, technically within the normal range of 70 to 100, it tells you nothing about what your glucose did after breakfast, how much insulin was required to bring it back down, or whether your cells are becoming progressively resistant to that insulin. Prediabetes and early metabolic dysfunction are among the most underdiagnosed conditions in preventive medicine. They do not announce themselves with the symptoms of full diabetes like excessive thirst, frequent urination, or unexplained weight loss until beta cell function has already declined by 50 to 70%. Usually progressing silently for years while causing progressive damage to blood vessels, nerves, and organs through mechanisms that operate even when fasting glucose remains in the normal range. The problem is that for decades, we have been told that normal fasting glucose means your blood sugar regulation is fine. Get your annual blood work, see that your fasting glucose is 94, and receive reassurance that diabetes is not a concern. Except that completely misses the 10 to 15 years of progressive insulin resistance and beta cell stress that precede the fasting glucose elevation that finally triggers a diabetes diagnosis. What we now understand from continuous glucose monitoring studies and metabolic research is that significant glucose dysregulation, particularly elevated post-meal glucose spikes and compensatory hyperinsulinemia, develops years before fasting glucose becomes abnormal. And most people have been living with dangerous metabolic dysfunction for a decade, while their normal fasting glucose provided false reassurance that everything was fine. Hi, I am Dr. Alex. I am an emergency medicine doctor, and after nearly 10 years in emergency departments, I have seen what happens when metabolic dysfunction that could have been detected and reversed early is not identified until it progresses to diabetic ketoacidosis, hyperosmolar hyperglycemic state, or the cardiovascular and renal complications of long-standing diabetes. And my goal now is to help people understand why normal fasting glucose does not equal normal glucose metabolism, what additional testing reveals the dysfunction that fasting glucose misses, and what interventions actually prevent progression from insulin resistance to diabetes. For the next several minutes, I want to walk you through exactly how glucose regulation works and why it fails, why fasting glucose is an inadequate screening test, and what you can actually do to detect and reverse early metabolic dysfunction based on the mechanisms we understand today. Okay, so if you are watching this video, you are probably concerned about your metabolic health despite being told your fasting glucose is normal. And I just want to take a moment here to make you a promise. I promise to keep creating the most helpful, evidence-based videos I possibly can, grounded in clinical research and the latest medical science to help you live longer and prevent the diseases I see filling emergency departments every single day. And all I ask in return is that you give this fairly new channel a chance and hit the subscribe button. If you get to the end of this video and you did not think it was worth your time, or you have not learned something genuinely useful about metabolic health, then feel free to unsubscribe. No hard feelings at all. But if you give me your time and attention, I will give you everything I have learned from over a decade in medicine and hundreds of hours reading endocrinology research. So please help me out, hit the subscribe button to help this channel reach more people like you, and let us continue with the video. How glucose regulation actually works. To understand why normal fasting glucose can coexist with dangerous metabolic dysfunction, we need to understand the systems that regulate blood sugar. When you eat carbohydrates, they are broken down into glucose and absorbed from your intestines into your bloodstream. This causes blood glucose to rise, which triggers your pancreas to release insulin. Insulin is the hormone that allows glucose to enter cells, where it can be used for energy or stored for later use. Insulin signals muscle cells to take up glucose for immediate energy or glycogen storage. It signals fat cells to take up glucose and convert it to triglycerides for long-term energy storage. It signals the liver to stop producing glucose and instead store incoming glucose as glycogen. Through these actions, insulin brings blood glucose back down to baseline within 2 to 3 hours after a meal. In metabolically healthy individuals, this system operates with remarkable efficiency. A meal containing 50 grams of carbohydrate might raise blood glucose from 85 to 120 milligrams per deciliter, trigger a moderate insulin response, and return to baseline smoothly without overshooting into hypoglycemia. The total insulin required is modest because cells respond readily to insulin signaling. Between meals and overnight, the pancreas secretes very little insulin, and blood glucose is maintained through hepatic glucose production that precisely matches the body's needs. Fasting glucose measured after this overnight period reflects the liver's glucose production and the minimal basal insulin required to keep that production in check. Insulin resistance changes this picture fundamentally. When cells become resistant to insulin, they do not respond appropriately to insulin signaling. Muscle cells take up less glucose, fat cells become less responsive. The liver continues producing glucose even when it should be suppressed. To compensate, the pancreas produces more insulin. Initially, this compensation is completely successful. Blood glucose remains normal because the elevated insulin overcomes the cellular resistance. You eat the same 50-gram carbohydrate meal, your glucose rises to 140 instead of 120. Your pancreas secretes 2 or 3 times more insulin than it used to, and the glucose eventually comes down. Your fasting glucose the next morning is still 92 milligrams per deciliter because your liver is still responding to the elevated baseline insulin by keeping glucose production in check. The blood test looks normal, but the underlying physiology is profoundly abnormal. What fasting glucose actually measures? Fasting glucose measures hepatic glucose production and the baseline insulin tone required to regulate it after an overnight fast of 8 to 12 hours. During this fasting period, your body has had maximum opportunity to stabilize blood sugar. Glycogen stores in the liver are being broken down at a controlled rate. Baseline insulin secretion is keeping this hepatic glucose output from rising too high. This represents the most favorable metabolic conditions for glucose control. The problem is that fasting glucose only becomes abnormal late in the disease process. Research published in Diabetes Care has documented that fasting glucose remains below 100 milligrams per deciliter until beta cell function has declined by approximately 50%. For years or even decades before that threshold is crossed, insulin resistance has been worsening and compensatory insulin secretion has been increasing. Post-meal glucose excursions have been climbing progressively higher. Hemoglobin A1C, which reflects average blood glucose over 3 months, has been creeping up within the normal range, but fasting glucose stays normal because the liver is still responding to elevated baseline insulin, and because overnight represents the period of lowest metabolic stress when compensation is most effective. Studies using continuous glucose monitoring in people with normal fasting glucose have revealed that significant numbers have post-meal glucose spikes above 140 or even 140/60 milligrams per deciliter. Levels associated with endothelial damage, increased cardiovascular risk, and progressive beta cell dysfunction. These spikes last for 2 to 3 hours after meals, creating cumulative glucose exposure that drives complications. Yet because fasting glucose is measured at the one time of day when glucose is most stable, these dangerous excursions are completely missed. The standard screening test is optimized to miss the problem until it is already advanced. The hidden metabolic dysfunction normal fasting glucose misses. The first and most critical hidden abnormality is elevated fasting insulin and insulin resistance. Fasting insulin is almost never measured in routine screening, yet it is the earliest detectable marker of metabolic dysfunction. In healthy individuals, fasting insulin should be below 10 micro-international units per milliliter and often below 5. In people with insulin resistance, fasting insulin can be 15, 20, or even 30, while fasting glucose remains completely normal. The elevated insulin is compensating for the resistance, keeping glucose controlled through brute force rather than through efficient insulin sensitivity. This hyperinsulinemia has direct harmful effects independent of glucose. Elevated insulin promotes fat storage, particularly visceral fat accumulation. It increases sodium retention by the kidneys, contributing to hypertension. It stimulates inflammatory pathways and promotes atherosclerosis. Research in the Journal of Clinical Endocrinology and Metabolism has shown that elevated fasting insulin predicts development of diabetes, cardiovascular disease, and metabolic syndrome years before fasting glucose becomes abnormal. The second hidden abnormality is exaggerated post-meal glucose excursions. When you consume carbohydrates, how high does your glucose rise and how long does it stay elevated? In metabolically healthy people, glucose might peak at 110 to 120 and return to baseline within 90 minutes. In people with insulin resistance but normal fasting glucose, the same meal can drive glucose to 150 or 170 and keep it elevated for 3 or 4 hours because the impaired insulin response cannot bring it down efficiently. These excursions cause oxidative stress, glycation of proteins, creating advanced glycation end products, endothelial dysfunction, and progressive beta cell burnout from the excessive demand. Yet standard screening would never detect them because testing only occurs in the fasting state. The third hidden abnormality is progressive beta cell dysfunction. As insulin resistance worsens over years, beta cells work harder to produce more insulin. This chronic overwork creates oxidative stress within beta cells, causes endoplasmic reticulum stress from the burden of insulin production, and eventually leads to beta cell apoptosis. The process is gradual. Beta cell mass declines slowly. Insulin secretory capacity diminishes incrementally. For a long time, the remaining beta cells compensate by working even harder, and fasting glucose stays normal. But once beta cell loss crosses a critical threshold, compensation fails, and glucose begins to rise. By the time fasting glucose reaches 110 or 115, you have already lost 50 to 70% of your beta cell function. The damage is largely irreversible at that point. The fourth hidden abnormality is hemoglobin A1C in the upper normal range. Hemoglobin A1C measures the percentage of hemoglobin molecules that have glucose attached, which reflects average blood glucose over the preceding 3 months. Normal is defined as below 5.7%. Prediabetes is 5.7 to 6.4%. But research has shown that risk increases progressively even within the normal range. An A1C of 5.5 carries significantly higher cardiovascular risk than an A1C of 5.0, even though both are normal. People with A1C consistently in the 5.3 to 5.6 range have measurably higher rates of progression to diabetes over the following decade compared to those with A1C below 5.2. Yet a person with fasting glucose of 95 and A1C of 5.5 will be told everything is normal despite having clear metabolic dysfunction in progress. And here is what you need to understand. This is not your fault. You went to your doctor. You had recommended screening. You were told your fasting glucose is normal. The failure is not personal. It is systemic. Standard screening protocols were designed decades ago when we had limited understanding of insulin resistance and progressive beta cell dysfunction. They measure the one variable, fasting glucose, that stays normal longest during disease progression. They do not measure insulin. They do not assess post-meal glucose. They do not evaluate insulin resistance using calculations like HOMA-IR. They wait for fasting glucose to cross into the pre-diabetic range, by which time you have already had years of dangerous metabolic dysfunction causing cumulative damage. The system is designed to detect late-stage disease, not early dysfunction, when intervention is most effective. What actually reveals early metabolic dysfunction? Once you understand the limitations of fasting glucose, you can request testing that actually detects early dysfunction. The first and most important test is fasting insulin, measured alongside fasting glucose. This allows calculation of HOMA-IR, the homeostatic model assessment of insulin resistance. The formula is fasting glucose times fasting insulin divided by 405. A HOMA-IR below 1 indicates excellent insulin sensitivity. Values between 1 and 2 are normal. Above 2 indicates insulin resistance. Above 3 indicates significant insulin resistance. This single calculation reveals metabolic dysfunction years before fasting glucose becomes abnormal, and it can be done with a simple blood test that adds minimal cost to standard screening. The second test is hemoglobin A1C, interpreted with optimal rather than just normal ranges in mind. Instead of accepting any value below 5.7 as reassuring, aim for A1C below 5.3, ideally below 5.1. If your A1C is 5.4 or 5.5, you do not have prediabetes by standard criteria, but you have clear evidence of higher average glucose than optimal and increased risk of progression. This should prompt further investigation and intervention, not reassurance that you are normal. The third approach is post-meal glucose testing, either through fingerstick measurements at home or through continuous glucose monitoring. Check your blood glucose 1 hour and 2 hours after meals containing significant carbohydrates. In metabolically healthy individuals, 1 hour glucose should not exceed 140 milligrams per deciliter, and 2 hour glucose should be back below 120. If you are consistently seeing 1 hour values above 150 or 2 hour values above 140, you have impaired glucose tolerance even if your fasting glucose is completely normal. Studies in diabetes have shown that elevated 1 hour post-meal glucose is a stronger predictor of future diabetes and cardiovascular disease than fasting glucose or even a 1C. The fourth test is an oral glucose tolerance test with insulin measurements. This involves drinking a standardized glucose solution and measuring both glucose and insulin at baseline, 1 hour and 2 hours. In insulin resistance, you will see exaggerated glucose excursions and markedly elevated insulin responses as the pancreas attempts to compensate. This test is more involved than fasting glucose, but provides far more information about how your body actually handles a glucose load, which is what happens every time you eat. What actually prevents progression to diabetes? The most powerful intervention is restoring insulin sensitivity before significant beta cell loss occurs. This means reducing the demand on beta cells so they can recover rather than continuing to burn out. Weight loss is the most effective single intervention. The Diabetes Prevention Program, a landmark randomized controlled trial published in the New England Journal of Medicine, demonstrated that losing 7% of body weight through lifestyle modification reduced diabetes incidence by 58% over 3 years in people with prediabetes. The mechanism is clear. Weight loss, particularly visceral fat loss, reduces inflammatory cytokines that impair insulin signaling. It improves hepatic insulin sensitivity, reducing fasting glucose and hepatic glucose production. It reduces the insulin demand on beta cells, allowing them to recover secretory capacity. The second intervention is dietary modification that minimizes post-meal glucose excursions. This does not necessarily mean extreme low carbohydrate dieting, though that approach works for some people. It means choosing carbohydrate sources that have minimal impact on blood glucose. Replacing refined grains and added sugars with whole grains, legumes, and vegetables reduces the glycemic load of meals. Combining carbohydrates with protein, fat, and fiber slows glucose absorption and blunts post-meal spikes. Eating smaller, more frequent meals rather than large carbohydrate-heavy meals reduces peak glucose excursions. Research in the American Journal of Clinical Nutrition has shown that reducing dietary glycemic load produces measurable improvements in insulin sensitivity and reductions in A1C, even without significant weight loss. The third intervention is regular physical activity, particularly resistance training combined with aerobic exercise. Muscle contraction stimulates glucose uptake through insulin-independent mechanisms, providing immediate blood sugar control. Regular exercise increases muscle mass, which serves as a metabolic sink for glucose disposal. It improves insulin receptor sensitivity at the cellular level. Studies have shown that 150 minutes per week of moderate intensity aerobic activity combined with 2 sessions of resistance training produces clinically significant improvements in insulin sensitivity, fasting glucose, and a 1C within 12 weeks, effects that are additive to dietary modification. The fourth intervention is adequate sleep, which is often overlooked but critically important for glucose metabolism. Sleep deprivation, defined as less than 7 hours per night, or poor sleep quality from frequent awakenings, impairs insulin sensitivity within days. It increases cortisol and sympathetic nervous system activity, both of which raise blood glucose and promote insulin resistance. It disrupts the hormones that regulate appetite and glucose metabolism, including leptin and ghrelin. Research in diabetes care has documented that improving sleep from less than 6 hours to 7 to 8 hours per night produces measurable improvements in insulin sensitivity and fasting glucose within 2 to 4 weeks. Now, I need to add an important medical caveat. If you have diagnosed pre-diabetes or diabetes, or if your glucose values are significantly elevated, you should be working with an endocrinologist or primary care physician who can determine if medication is appropriate. Metformin, the first-line medication for diabetes prevention and treatment, has been shown to reduce diabetes incidence in high-risk individuals and may be appropriate for some people with pre-diabetes who do not achieve adequate improvement with lifestyle modification alone. What I am describing are foundational interventions that address the root cause of insulin resistance and beta cell dysfunction. They are not replacements for medical treatment when medical treatment is indicated, but they are essential regardless of whether medication is used. What I see in emergency medicines, in emergency departments, we see the consequences of undetected metabolic dysfunction that progress silently for years. Diabetic ketoacidosis in people who had no idea they had diabetes until they presented in crisis. Hyperosmolar hyperglycemic state in elderly patients whose glucose had been creeping up for years while they were told their fasting values in the 90s were fine. Myocardial infarction and stroke in people whose glucose was pre-diabetic or diabetic for a decade before diagnosis, during which time the elevated glucose was causing progressive vascular damage. What becomes painfully clear is that by the time these acute events occur, years of preventable metabolic deterioration have already happened. The patient presenting in diabetic ketoacidosis often has medical records showing fasting glucose values that climbed from 90 to 95 to 100 to 105 over 10 years. Each time receiving reassurance that they were normal or just slightly elevated and not a concern. People who prevent diabetes are those who recognize and address metabolic dysfunction early. They understand that fasting glucose of 95, while technically normal, warrants investigation, if accompanied by other signs like weight gain, family history, or symptoms of insulin resistance. They request additional testing including fasting insulin, A1C, and post-meal glucose assessment. They implement dietary modification, weight loss, exercise, and sleep optimization when testing reveals early dysfunction. They arrive at 65 or 70 with normal glucose metabolism and intact beta cell function. Those who rely on fasting glucose alone and accept reassurance that 95 is normal often arrive at 65 with diabetes requiring multiple medications, complications already developing, and irreversible beta cell loss. Same starting point in their 40s. Completely different metabolic health in their 60s and 70s. The divergence happened because one group recognized that normal fasting glucose is not sufficient to rule out dangerous metabolic dysfunction. The bigger picture is that metabolic health is not determined by a single fasting glucose measurement. It is determined by insulin sensitivity, beta cell secretory capacity, post-meal glucose handling, and the cumulative glycemic burden your body experiences over days, months, and years. Fasting glucose is the last variable to become abnormal in the progression from insulin resistance to diabetes. By the time it crosses into the pre-diabetic range, you have already lost years of opportunity for intervention when lifestyle modification alone could have prevented progression. Normal fasting glucose provides false reassurance that masks underlying dysfunction until it is far advanced. So here is what I want you to take away from this. If your fasting glucose is normal, that is valuable information, but it is not sufficient to determine that your metabolic health is optimal. Request additional testing, including fasting insulin and calculation of HOMA-IR. Pay attention to where your A1C falls within the normal range, aiming for below 5.3 rather than accepting any value below 5.7. Consider post-meal glucose testing to assess how your body actually handles carbohydrate loads. If testing reveals insulin resistance, elevated insulin, or impaired post-meal glucose tolerance, recognize these as opportunities for intervention before significant beta cell loss occurs. Implement dietary modification that reduces glycemic load, achieve and maintain healthy body composition with minimal visceral fat, engage in regular exercise, combining resistance and aerobic training, and prioritize sleep quality and duration. These interventions address the root causes of metabolic dysfunction and can prevent progression to diabetes when implemented early. The return on that investment is measured in decades of preserved metabolic health, freedom from diabetes medications, and avoidance of the cardiovascular, renal, and neurological complications that diabetes creates over time. And finally, please subscribe to the channel if you found this video useful. It helps me reach more people trying to understand their metabolic health and prevent diabetes. Thank you for watching.